So first, I do want to thank Arita McCoy, who's our lovely nurse practitioner who actually put this slide deck together. I cannot take credit for that. I just, put in a few updates. So we're going to review some basics first. Some of you may already understand this really well, but it's really important to understand what Parkinson's disease is and what causes it in order to understand why our treatments work and how they work. So Parkinson's disease, it's a progressive chronic neurological disorder, and it's caused by degeneration of the substantia nigra, which is an area in the brain that produces dopamine. And therefore, the basis of most of our treatments is how can we increase dopamine in the brain? Because patients with Parkinson's disease are lacking dopamine due to the loss of these cells in the substantia nigra. So this is an illustration of the brain. So if you can imagine the brain being cut this way, I don't know if you can see me, but down the side like this. So you're looking at the brain head on. And deep inside the brain are these small structures that are involved in modulating how much a person moves and also restricting how much a person moves. So here we have the putamen, the caudate, and the thalamus. All of these communicate together to modulate the amount of movement that a person does. And the most important signal in this pathway is dopamine, which comes from the substantia nigra. So this little tiny area of the brain is so important in what it does. And this on the right side here is a illustration of a neuron. So you have the cell body and an axon. Those are the parts of the neuron. And when a signal is sent, it's sent down to all the way down the axon, and it's released at the end here. So this is the nerve terminal, and here we have it zoomed in. So you have an impulse message saying, the brain is communicating what it wants you to do, what your body wants to do. And it releases chemicals called neurotransmitters. And these neurotransmitters help carry out the information that the brain is trying to communicate to the body. And so the neurotransmitters attach to a receptor. And a lot of our medications modify how these neurotransmitters work in the brain. So dopamine that's produced by the substantia nigra is a neurotransmitter. And as we've already said, in Parkinson's disease, it tends to be lacking because we have loss of the substantia nigra slowly over time. So this is a picture of the deep area in the brain. So this is, it's called a gross pathology sample. Basically, it's looked at after someone's passed away. And you can see this dark area here on both sides. This dark area is called the substantia nigra. So the name partly comes from the color, this black color here, because dopamine is pigmented. And you can see in a person who has Parkinson's disease that they have loss of that pigmentation, which indicates that some of the cells here have degenerated. So the main signs and symptoms of Parkinson's disease, well, first is bradykinesia. That means slowness of movement, because somebody who has loss of cells in the substantia nigra and loss of dopamine will have slower movements. You need dopamine to move. And it's a little bit more complex than that, because then you also have tremor, which is too much. It's a hyperkinetic movement, so it's too much movement. And then rigidity or stiffness. So these are the main cardinal symptoms. And in order to be diagnosed, you have to have Parkinson's, you have to have bradykinesia plus or minus tremor, plus or minus rigidity. So there are people who have Parkinson's disease without tremor. And I think most people, when they think about Parkinson's disease, they think about the tremor because that's an obvious or notable symptom, but it's very possible to have just bradykinesia and rigidity. And then balance can be affected as well, although this usually happens later in the disease. We're talking about more than 5 years in, and not necessarily early on. And then, of course, as I'm sure many are familiar with, there are many signs and symptoms that can occur in Parkinson's disease. So small handwriting, people become a little bit more hunched over, stooped posture, shuffling gait. So this happens because a person with Parkinson's disease cannot lift their feet as high as they used to, and they cannot have a normal stride. So the stride becomes shorter. Hypomemia is just a fancy word for a sort of flatness to facial expression. Constipation, urinary urgency, drooling. So lots of different parts of the body are affected. And so it's much more than just these symptoms here that can happen. It's not to say that all of these symptoms have to happen or will happen, but these are common symptoms that we see in Parkinson's disease. And a lot of this is also referred to as the non-motor symptoms, right? So this is the motor symptoms are the slowness of movement, the tremor, rigidity, because there's a problem with motor, right? And non-motor symptoms are all the other different things that can happen. So, and this can include neuropsychological problems such as depression, anxiety, bradyphrenia. So bradyphrenia is just slowness of thinking. Again, dementia does not have to happen in Parkinson's disease. It's something that can happen later on in advanced stages. And same thing with psychosis or hallucinations. They don't have to happen, but it can happen later on. So when we talk about treatments, most of the treatments we're going to talk about today are treatments for this, right? To make a person with Parkinson's disease move faster, to try to calm down the tremor, to loosen up the joints and muscles so that you don't feel rigid. And however, in real life and in a practical way, we also end up addressing a lot of these other symptoms too, such as urinary frequency and urgency, constipation we treat. And if someone has depression, anxiety, which are quite common, because if you think about it, dopamine is also one of those happy chemicals in the brain. So when those are lower, that can also affect mood. So we also tend to try to target all these other symptoms as well. But today we're mostly going to focus on the medications that are specific to Parkinson's disease for the treatment of the motor symptoms. So Parkinson's disease is becoming more and more common as Americans become older and as Americans are living longer. So about 1 million Americans are affected at any one time, and there's about 50 to 60,000 diagnosed each year. Most commonly, the age of onset is between 55 and 65 years old. And there's a slightly higher incidence in men. But as you note in the last bullet here, only a few go into nursing homes and reach the end stage of the disease because it is slowly progressive if it's a pure Parkinson's disease that we're talking about. Now, there are other conditions that look similar to Parkinson's disease, are not exactly the same as Parkinson's disease. For the purpose of this talk, we're only talking about regular idiopathic Parkinson's disease and not the cousin disorders that sometimes we often see. And in Parkinson's disease, we stage the disease. So Hohen and Yahr, those are the scientists that came up with this staging system. So 0 means really no symptoms at all. 1 means that only one side of the body is involved, and it's very common and typical for Parkinson's disease to start on one side of the body and usually stays on one side of the body for a long time before spreading to the other. But stage 2 is when you have involvement of both sides of the body, but the balance is not affected. And as we said, later on, as the disease advances, balance can be affected. So that's stage 3, when people have a little bit of instability with balance. A pull test is the test that we do in the office where your physician stands behind you and literally pulls you backwards and see how well you can recover your balance. So that's part of the staging system, is how a person does with that pull test. And then severe disability is stage 4, when They cannot walk or stand unassisted, and stage 5 means wheelchair bound. And as I said previously, not everybody reaches stage 5. So this is how Parkinson's disease is growing in the world and what's expected from 2005 to 2030. So you can see that, you know, the United States and Europe are having 50 to 100% growth, so nearly doubling our population. And that really has to do with people living long enough to get diagnosed with more conditions, right? And here's another way of kind of showing the same information. So it looks like for some reason China has a higher burden of Parkinson's disease compared to other places. So in the US it's 8%, China's 48%, and that was back in 2005. And this is the projection for 2030, which is a little bit higher in some places. Okay, so now let's actually go on to treatment. So Parkinson's disease has multiple treatment modalities. For the purpose of this talk, we're primarily focusing on the medication management, but I do want to emphasize the importance of physical therapy, occupational therapy, and speech therapy, and exercise in general. So exercise has been shown in some studies to actually slow down progression of the disease, which no medication can do at this point. So we highly, highly, highly encourage our patients to exercise. And I can tell you from my personal experience, and I'm sure my colleagues would say the same, that patients who keep up with exercise in the long run do a lot better than people who do not exercise. So I'm going to get off my pedestal about exercise after this slide and focus on medication management, and we'll talk a little bit about the surgical treatment options as well. And for diet, the diet that's typically recommended is the Mediterranean diet. So that's the one that's been studied to have some protection for the brain. So, and I also want to say that although a cure does not exist for Parkinson's disease, there are a lot of people who are working on developing new and effective treatments and looking for, ultimately we are going to be looking for a cure, but that's not quite there yet. So as you can see, there's a lot of medications that are used in Parkinson's disease. I'm sure most of you are familiar with Carbidopa, Levodopa, because that is considered the gold standard medication. But there are a lot of other options here. And some of these medications can only be used in conjunction with Carbidopa, Levodopa. And some of them can be used alone or in combination. So there's lots of ways to do this, and it can be quite complicated. So definitely, ask questions at the end if any of this doesn't make sense as we go through it. But we're going to go through most of these, actually all of these medications in this hour. And I pretty much already spoke to this, that there are no medications that have been proven to stop the progression of Parkinson's disease. And, one thing very important to address and understand is there's a lot of people who are concerned that starting a medication means that you develop tolerance to a medication or that it loses its effectiveness early. And I want to point out that that's not true. There was actually a big landmark trial that compared patients who started Carbidopa, Levodopa, and similar medications earlier in the disease and compare them to patients who waited. And at the end of the day, both patient groups ended in the same place. So it didn't change the progression of the disease in any way. Really, what we're looking at when we suggest a medication is your quality of life today. So knowing that in the long run, these medications are not going to make your disease progress faster, and it's not going to slow down the disease progression either. What we really have to focus on is what are we doing for you today that is making your quality of life good right now? Because as the disease progresses, that your quality of life can change. And if we can do something to maximize your quality of life, that's what we should be focusing on. But I do want to allay any fears that starting carbidopa, levodopa at any time in the disease course would somehow make you tolerant of the medication. Really what happens is that because the disease is progressive, your brain and your body will require more of the medication over time. And so it's not tolerance that you're building up, but rather you're just needing more of the medication because the disease itself is changing. Okay, so now we're going to start with, I feel like I'm missing a slide here, actually. No? Okay, so we'll keep going. Hold on, I'm just looking ahead to see. There was a nice slide, and it seems to be gone. Okay, I don't know what happened to that slide. So hopefully I'm going to try and describe it as best I can. So basically, in the brain, maybe we can go back and look at this picture here. Okay, right here. So what happens is that dopamine is released from the nerve, and it connects to what we call the postsynaptic terminal, and there's dopamine receptors here on this side. And many of our medications act on both sides of this. So in the brain, there are enzymes that break down dopamine. So one enzyme is called monoamine oxidase, MAO for short, and another enzyme is called catechol O-methyltransferase, or COMT. And we're going to go over this all again, so don't feel like you have to memorize it right now. But those enzymes break down dopamine. MAO actually works in the brain itself, and COMT actually works outside of the brain, but both of them break down dopamine. And so some of our medications will block those enzymes to increase the amount of dopamine that is hanging out in the brain. So it's not that you're making more dopamine, the brain is still producing the same amount of dopamine and releasing it, but they're hanging out longer around here because the enzymes that break them down are being blocked by the medication. And then there are medications called dopamine agonists. Dopamine agonists are chemicals that are similar to dopamine and look structurally similar to dopamine. And so they kind of imitate dopamine and attach to the dopamine receptors. But they're not as potent as dopamine itself. And then we have dopamine itself. So dopamine cannot cross into the brain. There's a barrier around the brain called the blood-brain barrier. And pure dopamine cannot cross through that barrier. So that's why it's given as levodopa. So normally dopamine is produced from another chemical called tyrosine. Tyrosine is broken into levodopa. Levodopa crosses into the brain and gets converted into dopamine. So we give levodopa because it can cross directly into the brain. If we gave you straight up dopamine, it's not going to get into the brain itself. And the reason why we have carbidopa, right? It's a two-part medication, carbidopa, levodopa. Carbidopa is is a part of the medication that actually blocks some of the conversion of levodopa outside of the brain. So levodopa can be converted into dopamine both outside of the brain and in the brain. And if you block the conversion of levodopa outside of the brain, you're allowing more of that levodopa to go into the brain so that there's more dopamine in the brain. And it also helps reduce nausea, the carbidopa, which is a common side effect, which we'll talk about. Okay. So MAO-B inhibitors work by blocking monoamine oxidase, which is the enzyme that breaks down dopamine. And same thing with COMT inhibitors, right? They inhibit COMT or catechol O-methyltransferase, which is another enzyme that breaks down dopamine. And then we talked about dopamine agonists, which imitate dopamine. They're chemicals that hit the same receptors and help produce the same effects as dopamine. And then there's levodopa, which crosses into the brain, gets converted into dopamine, And that comes in many different forms, which we'll talk about. Then we have anticholinergics. So anticholinergics are medications that work on basically increasing acetylcholine. So there's a balance between dopamine and another neurotransmitter, acetylcholine, that's thought to play a role in Parkinson's disease. But these medications do not work as well as dopamine itself, but they do have a role for certain symptoms. And then amantadine, we'll talk about in more detail too, has a very specific role. And then this is a newer medication that we'll kind of talk about at the end. But the main drugs that are most commonly used are Carbidopa, Levodopa, and its various forms, dopamine agonists, the MAO-B inhibitors, and the COMT inhibitors. Okay, so this is the MAO-B inhibitors in a little bit more detail. So the main ones that you may come across are selegiline and rasagiline. Rasagiline is a newer version and a little bit more tolerable compared to selegiline. There's not a huge difference between the two, but rasagiline is structurally a little bit different. And the main thing is that selegiline can make people feel a little bit jittery, and rasagiline does not do that. But both of them help improve motor features. They can be used alone or in conjunction with levodopa. And these are the main side effects here: some nausea, dry mouth, lightheadedness, and constipation. Usually the side effects you'll see are ones that are similar to dopamine, because what we're doing, right, by inhibiting the chemical or inhibiting the enzyme that breaks down dopamine, we're creating more dopamine in the brain. So these are side effects from having more dopamine in the brain, essentially. And then one thing that's worth mentioning with MAO-B inhibitors is that there's the wine and cheese effect. I'm not sure if you ever heard of that, but generally when you're on MAO-B inhibitors, they tell you to avoid wine and cheese because they contain a chemical called tyramine. And tyramine is a chemical that's also broken down by the same enzyme. So then if you're blocking this enzyme, you can get a buildup of tyramine, and tyramine can raise the blood pressure to dangerous levels potentially. So if you're on this medication, generally it said, don't eat too much cheese. I wouldn't say none at all, but, very little. And this at the bottom here is pretty rare, serotonin syndrome with MAO-B inhibitors. So MAO-B is an enzyme, we said, breaks down dopamine, but it also works on many other chemicals in the brain too, including serotonin. And serotonin is an important neurotransmitter of the brain. It's involved with mood. So it plays a lot of different roles, both in the brain and outside the brain. And so there's MAO-A and there's MAO-B, as you can imagine, right? If there's an MAO-B, there must be an A version. So MAO-A is the primary enzyme that breaks down serotonin. So generally, when we give an MAO-B inhibitor and somebody's on an antidepressant, the concern is, are we increasing serotonin too much in the brain? But it's very rare because, like I said, serotonin is primarily broken down by MAO-A. But some of these medications, including selegiline, when given at a high enough dose, can start, in addition to blocking MAO-B, can also start blocking MAO-A. So generally, if you're going to be at risk for serotonin syndrome, it's at higher doses of these medications that we use to treat Parkinson's, and not necessarily at the low dose. But it is a major syndrome that comes with fevers, and often people can be hospitalized from this. So it's something that's serious, but very rare. Okay, so dopamine agonists. So these are, again, the medications that are chemicals that imitate dopamine and attach to the same receptors in the brain as dopamine. And again, they help improve all the motor symptoms, right? So helping people walk faster, helping people to have less tremors, etc. Not as potent as levodopa though. But the upside of that is then there's less tendency for dyskinesia. And just for anyone who does not know what dyskinesia is an excessive type of movement where a person cannot sit still. They look like they're fidgeting, kind of, Michael J. Fox has a lot of dyskinesias. So if you've seen him in interviews, you'll see that he's constantly moving around. He can't really sit still very well. And that can be seen later in the disease course as a side effect of some of the medications. So main side effects with this one are, again, some of the same things, some nausea, dizziness, lightheadedness, can cause some swelling in the feet. But the biggest side effects that we worry about is sudden sleep attacks, that people can just suddenly fall asleep on this medication, and then compulsive behaviors. So someone could potentially develop impulse control disorder, or ICD for short. And it's a hyper compulsive behavior. So, if somebody's on this medication and then they start shopping excessively, or they, gamble all their money away, things like that. So very impulsive, not thinking through the consequences of behaviors. Can be seen with dopamine agonists. Generally, that's seen more in our older population. So usually if we're going to use dopamine agonists in a patient, it's usually someone who is young, younger than age 70, and probably newly diagnosed, has not really been on any other medications yet. Those are the people we're more likely to use a dopamine agonist in. And I pretty much try not to prescribe this medication for anyone older than 70, because the risk of having these compulsive behaviors is much higher in that population. All right. So carbidopa, levodopa, we already talked a little bit about, and we already talked about how dopamine does not cross the blood-brain barrier, but levodopa does, and it crosses over, gets converted into dopamine. And we talked about how carbidopa blocks the breakdown of levodopa in the body, outside of the brain, which means that more levodopa can cross into the brain. And this also helps reduce the side effect of nausea. So it is the gold standard medication. It was developed in the 1950s and 1960s because at that time they saw that in rat models, if they depleted dopamine in rat models, the rats looked like Parkinson's disease. And so then, of course, the next step is to think, maybe if we replace that dopamine, the rats would do better, and they did. And so then they started expanding that to human beings and seeing the same effect. So I want to say, when it was FDA approved, I think it was 1969 was when it really became popular. And it really changed the world of Parkinson's disease. If you can imagine, before this point, there wasn't a lot of treatment options that were really effective. And we do know carbidopa, levodopa is very effective, but like we said, it doesn't stop disease progression. And so we have to change the medication regimen over time. So in the beginning, someone may start on this medication as 1 tablet 3 times a day, and the medication has a 90-minute half-life. And in the very beginning of the disease, I think I have a slide on this, yes. So in the beginning of the disease, the treatment response is really good. And for many people, the medication will last 6 to 8 hours. And oftentimes in the very beginning, when people are just starting to have this disease, starting to have symptoms, and they're put on carbidopa, levodopa, they don't notice whether they're really on the medication or off the medication, because they sort of have this even keel response here. So there's this window here where, so if you're in this gray zone, you're good. You feel happy, you feel like you can move well, the tremor is gone, your speed of movement is good. And I've had patients who are early in the disease course tell me, when I'm on this medication, I feel completely normal, and I feel like most people cannot even tell that I have Parkinson's disease. And then as the disease progresses, that window becomes smaller. So how long the carbidopa, levodopa, how long each dose lasts becomes shorter. So you can see 3 to 5 hours in the moderate stage of the disease. And the ups and downs of this becomes more exaggerated. So there's a higher risk of dyskinesia. So that's when you go above this window and you have too much movement. So the dopamine, this is kind of, if you imagine, this is sort of like the peak effect of the medication. So in the beginning, you have like this little peak and like a nice steady amount of dopamine in the blood. And here it's peaking too quickly and then dropping off, right? And so when it peaks like that, that's when you can get too much movement, called dyskinesias. And then it drops off and you feel like the medication's wearing off. So now, usually at this point, my patients will tell me, I know when it's time for my next dose. I can tell if I'm late because the medication's wearing off and my tremor comes back, or I'm feeling stiffer and I need my next medication. And then, of course, sometimes they can develop dyskinesias at this point too. And then in the advanced stages of the disease, now the medication lasts about an hour and a half. And so as the disease progresses, what ends up happening is that we start scheduling the dopamine doses closer together. So someone starts off as one tablet, maybe 8 hours apart or 6 hours apart, and take it 3 times a day while they're awake. And then I have patients who are in advanced stages who may be taking the medication every 2 hours or every 3 hours and taking higher doses to try to get into the same window here, right? So this window is narrowing as the disease goes on. And really the reason for that is, again, because the brain is losing dopamine cells. So the less dopamine cells you have, it's kind of like you have less to work with. So even though you're flooding the brain with dopamine, now the person's going to be more sensitive to the medication and have a big peak and a fast wear off. And so the challenges are to try to keep people inside this window. And a lot of the medications that we'll use with Carbidopa, Levodopa, the purpose is to try to keep people in this window. So some of the medications, when we use it in conjunction with Carbidopa, Levodopa, helps to extend the length of each dose. So we already talked about how, like, for example, COMT, right? COMT is one of the enzymes that breaks down Carbidopa, Levodopa. If we block that enzyme, you're increasing the amount of time that dopamine is hanging around in the brain. So that can help increase this window maybe by an hour. And that's a good thing. And then there are medications to help treat dyskinesias. Suppose somebody needs this amount of Carbidopa, Levodopa to move, to get out of a chair, to be active. And if you lower it, the dyskinesias go away, but then that person is not doing as well from a motor perspective. So you can add on medications like Amantadine, which help to reduce dyskinesias. So this is a slide discussing motor fluctuations. So motor fluctuations are alterations between periods of being on, which is when patients feel like they're having a good response to the medication, they feel like they can move, they can walk, they can maybe run a mile, and then being off when they feel like the symptoms of Parkinsonism comes back, right? The slowness of movement, the tremors, the stiffness. And so these are examples of symptoms that people feel in either end. So on time, less tremor, bradykinesia and rigidity, improved gait, better balance. However, you can also have what we talked about before, dyskinesia. Dystonia is when you have contractions of muscles, over contractions, and actually can cause twisting of the hand or the foot or curling of the toes. And you can see that actually as I've seen that as more as an off symptom, but I guess it's also possible as an on symptom as well. So it can happen on either end of the spectrum. And off time, again, is more the Parkinson symptoms come back, the tremor, the bradykinesia, rigidity. Sometimes people, especially later in the disease, in more advanced stages, feel like they get freezing. So that's when they're trying to walk and suddenly the feet is stuck to the ground and you want to move forward, but you can't. So it's like your feet are glued. And again, we talked about how Parkinson's disease is not just a motor problem, but because dopamine is a chemical that's involved in many different parts of the brain, people can feel anxiety and depression as an off symptom when the dopamine is wearing off. So COMT inhibitors, we talked a little bit about already, that they can reduce the off time and lengthen the on time. And potential side effects, I haven't really seen much confusion or hallucinations in people who use COMT inhibitors. I think the reason why these end up potentially being side effects is that if you have too much dopamine in the brain, you can have hallucinations or confusion. So at too high of a levels. So technically anything that's going to increase the amount of dopamine you have in the brain can do the same. Discolored urine can have like a rusty color. This is not actually harmful. It's just, can look scary. So something that we just warn our patients about, that can happen, but otherwise there's nothing really to do about it. And the main medications that we see are entacapone and tolcapone. So those are both types of COMT inhibitors. And then there is Stalevo. So Stalevo is carbidopa, levodopa, and entacapone. So it's nice because it's only one pill. Entacapone is actually taken with every single dose of carbidopa, levodopa. Tolcapone is actually taken 3 times a day. And opicapone is only taken, I believe, once a day. So there's pill burden involved here, right? As the disease advances and we're adding on more medications, it's a lot of medication. So if insurance can approve Stalevo, it's really nice because it just reduces the amount of pills to take. And again, none of these medications can be taken by themselves. They have to be taken with carbidopa, levodopa. And that's primarily because this enzyme, it doesn't act inside the brain. It actually acts outside the brain, breaking down levodopa, breaking down dopamine. So we want to block this enzyme to allow more levodopa to go into the brain. So amantadine, it's a complicated medication in some ways in terms of how it works, but it was actually originally designed as an anti-influenza medication back in the 1960s. But some astute observers noticed that patients taking amantadine who had Parkinson's disease were doing better, particularly in terms of tremor. So tremors have more of a tendency to respond to amantadine than any other symptom of Parkinson's disease. And so it can provide immediate benefit for Parkinson's tremor, but usually the effect will wane after weeks or months. So it's not the most effective medication in terms of all the medications we talked about for Parkinson's. It acts on the N-methyl-D aspartate receptor, which helps to increase the amount of dopamine again. So everything, again, is about increasing the amount of dopamine. And main side effects, again, are the same. So, these are all side effects that can happen when there's too much dopamine in the system again. So can keep you awake late at night, confusion, nausea. Oh yeah, so an important side note about amantadine is that you don't want to take it right before bed. This is a medication that's dosed twice a day. And so when people think twice a day dosing, they usually think like breakfast and right before bed, but actually the second dose should be sometime before 5 p.m. so it doesn't cause insomnia. And potentially it can cause hallucinations as well. So again, I tend to avoid this medication in older patients. And really, it's only really useful for a couple of things, which is tremor control and also for dyskinesia, specifically really helpful for dyskinesias. So if somebody has carbidopa, levodopa, and they're developing dyskinesias and we cannot lower the levodopa because they need it to move well, then we can try amantadine to help reduce the dyskinesias that are happening. A very rare side effect is called livedo reticularis. So this is a particular type of rash that happens primarily on the legs. It's kind of like a bluish, reddish rash, and it looks like a lacy pattern to it. And it's not harmful. It's just, cosmetically maybe not what somebody would want, but it's not a harmful side effect. So if somebody has livedo reticularis, but they're doing really well on amantadine, it would not necessarily be a reason to discontinue unless you're really unhappy with this rash. Anticholinergic agents. So these are not first-line agents for Parkinson's disease. They also work on the acetylcholine dopamine balance. And I also do not use this medication in older individuals, particularly over 70, maybe even over 60, because it does have a high risk. So out of all these medications, this one will have the higher risk of confusion and hallucinations and affecting memory. And then it can also cause urinary retention and dry mouth. So based on those side effects, I generally don't use this medication for Parkinson's disease, except for if somebody also has dystonia, again, when you have over contraction of muscles that cause twisting of a limb, like twisting of the hand or feet or curling of the toes or curling of the fingers. Sometimes I will use this medication, but that's really for people who don't want to do Botox. For example, one of my patients has a major needle phobia, and botulinum toxin injections is the first line treatment for dystonia, and we know it works really well. And she knows that as well, but she's has a needle phobia, so we tried Artane instead, but it doesn't work as well, honestly, as Botox does, and so I don't really use these medications very much. Okay, so let's talk a little bit about what's new. This is kind of going over the past 7 to 10 years of new treatments. Some of them I did mention on the first slide, but we're going to go in a little more detail. So safinamide is another MAO-B inhibitor, and this was approved for improvement of on time, so increasing the amount of time that patients feel like they're on and their medications are working well. And the advantage here was that it did not show as much dyskinesia compared to the other MAO-B inhibitors in the studies. Again, this was only used in conjunction with other PD medications like Carbidopa, Levodopa. Rytary. So Rytary is a great medication because, you know, we talked about how Carbidopa, Levodopa in the beginning of the disease can last 6 or 8 hours, but then in people with advanced stages of Parkinson's disease, it can only last maybe 2 hours. So this is one way to try to get around that, what we call motor fluctuation, that up and down roller coaster of Carbidopa, Levodopa is on, and I have great tremor control, and I have great walking and balance, but maybe I have a lot of dyskinesias, and then boom, it's wearing off, and now I can't move well, I can't walk well. So Rytary is a formulation, it's still Carbidopa, Levodopa, but it contains beads that dissolve and absorb at different rates. And so you'll have some of it that'll kick in right away, and then you'll have an extended release version that will last longer. So it's designed to last about 6 hours. And like I was saying, primarily we use it in advanced disease to help reduce that up and down motor fluctuations, get people off of that roller coaster. The idea being that you have a smooth amount of dopamine in your system and trying to reduce those peaks where you have dyskinesia and those falls where you feel off the medication and you don't feel good. I realize there's not a slide on this, but Carbidopa, Levodopa, or Treament comes in an immediate release version and a long-acting version too. So that's different from Rytary. There's Carbidopa, Levodopa, CR or XR, continued release. And that one, well, the problems with that one is that it doesn't fully get absorbed in the gut. So about 70% of it gets absorbed and, is available as a drug in your bloodstream and in your brain. And it doesn't kick in right away. So it takes time to kick in, but it does last longer. So Rytary is kind of like the better version of that because it kicks in faster and it lasts longer. However, I do want to caution people when they think about this drug is that just like Carbidopa, Levodopa, we do have to tinker with it and titrate it. So sometimes when your neurologist changes you from Carbidopa, Levodopa to Rytary, they may not be an immediate difference or effect because we may start at a certain dose and undershoot or overshoot how much dopamine you really need from the Rytary. And so sometimes you have to, change the dose a little bit here and there to try to get to that right place, that smooth spot where you're not having as much up and down. Duopa, so this is a way to deliver Carbidopa, Levodopa directly into the small intestine. And it's a continuous delivery of levodopa. So it helps to also smooth out that up and down phase. I think I have a picture here. Yes. Okay. So Duopa is a pump. So this is called a cassette. This contains the medication. It has to be refrigerated. And this itself is the pump that we program. And this is what tells how much to be released. And there is a procedure that has to be done by a GI specialist where they put a PEG J tube into the stomach and into the small intestine. So the G tube ends in the stomach, and then there's a J tube that goes all the way through the large intestines and ends in the jejunum. And so you have basically, the way it works is when you first wake up in the morning, you push a button and it gives you that first morning bolus. So it's a larger amount to kind of kick off your day and start going. And then you have a continuous amount that's constantly being released for about the next 12, 15, 16 hours. It can be running for 16 hours, depending on how long your day is and how long you're awake. And then overnight, you turn it off. And then in the morning, you put in a new cartridge and you kind of start over. So it's really helpful to, again, avoid like those sharp peaks and dips because you're having a nice steady release of levodopa. And you can really, really control how much levodopa is going in, because since it's in this type of formulation, you're controlling by the milliliter. And I'm forgetting the conversion off the top of my head, but it's not a lot of levodopa per milliliter. So you can really, really fine tune how much carbidopa, levodopa you're giving someone. Of course, the inconvenient part is having a pump, right? So people do have to wear this pretty much all day, and they do make special vests that can carry this, or special shirts or special straps. So there's options on how to try to make this more fashionable. Okay, so opicapone is a newer COMT inhibitor. The most convenient part of this is that it's once a day dosing. So if you remember, entacapone is given with every single dose of carbidopa, levodopa, and this one is only once a day. So that's really nice. And it's just taken at bed, and trials show that it was efficacious, that it added an hour of on time daily compared to people who only took carbidopa, levodopa. Of course, a lot of these medications are not compared to others in its class. It's usually compared to the gold standard medication of carbidopa, levodopa. So it can make people feel a little bit drowsy, and it can drop the blood pressure a little bit. So those are things to be careful of. And honestly, I've not really used this medication a lot. I think it's hard to get insurance approval, and a lot of times the newer medications that are more convenient, like once a day dosing, tend to be more expensive, unfortunately. Inbrija, so this is another levodopa medication. So it is, in a way, not any different than carbidopa, levodopa, except in how it's delivered. So it's inhaled, and it's considered like a rescue therapy. So it cannot replace pills because it will, it works really quickly, but it also wears off really quickly. So it's really designed for people who may have these sudden off periods where the medication that they take by mouth suddenly wears off, and they need a bridge between that moment and the next medication. So they can inhale this, although the main side effects in this is coughing, and it does increase the risk of upper respiratory tract infections. Okay, and then there is a medication that you place under the tongue called MAO-B is the brand name, sublingual apomorphine. And it's also similar to Inbrija, the inhaled levodopa. It's kind of the same idea where it can help with unpredictable off time. So, if somebody is out and about trying to go about their day and suddenly they're off and they don't expect it, which in advanced stages, it can become more unpredictable. This medication can help, again, to bridge the time to the next dose. However, it has a higher side effect of nausea, so that's why it's required to take a medication for anti-nausea for 3 days prior and several weeks after starting. And again, this can also drop blood pressure. So dopamine can lower blood pressure a little bit. Carbidopa, levodopa can do it a little bit. I think this one, because it hits the system faster, can do it even more so. So something to be aware of. Okay, so we talked about Amantadine, which was one of the anticholinergic medications that are primarily used to treat either tremor in Parkinson's, but mostly used to treat dyskinesia. And the thing about Amantadine is that it's not as long acting and you have to take it twice a day. So there's two medications that came out that are basically extended release of long acting medications, but they're basically Amantadine in a long acting form, and they can be taken once a day. And it's pretty much the same type of side effects that can happen as Amantadine. So the biggest ones to watch out for are cognitive impairment, so problems with thinking and memory, and hallucinations. And so again, I try not to use this in somebody who already has problems with memory or already has experienced some hallucinations or are much older and more likely to develop those problems. And then of course, it's, I believe, cleared by the kidney, and that's why somebody with kidney disease, you have to be very cautious in the dosing. So Govcori is basically the same idea as Osmolex. It's also a long-acting, extended-release version of Amantadine. Osmolex is taken in the morning. Govcori is taken once a day before bedtime. So they're both once a day, and they're both approved to treat dyskinesias, and same side effects. Okay, so other medications. So there's a few medications to treat orthostatic hypotension. So orthostatic hypotension, really quickly, is a symptom that's seen in moderate to advanced stages of Parkinson's disease, where when a person stands up quickly, the blood pressure drops and people can feel lightheaded or dizzy. And the reason why that happens is because what normally is supposed to happen is that, when you stand up quickly, all your blood pools to the bottom of your body, right? And you can imagine that can make anyone lightheaded. But the body compensates very quickly by increasing the heart rate and increasing the blood pressure to pump up all the blood, all over the body, and especially to the brain. And in a person with Parkinson's disease, that part of the nervous system that makes that happen is affected. And so that compensation, where blood pressure is going to drop as you stand quickly, that compensation to make that blood pressure go up quickly is gone. And that's what we call orthostatic hypotension. So it can be very bothersome, where people feel lightheaded, dizzy, or feel like they can pass out. And so sometimes we give medications to try to treat this. First we'll try suggesting drinking more water and fluids, especially fluids that contain electrolytes, to help increase the volume in your bodies to avoid those blood pressure drops. And some people will take salt tablets. You can do compression stockings to help push the fluid up the body. And if those things don't work, then we turn to medication. So Northera is specifically approved for orthostatic hypotension in Parkinson's disease. Unfortunately, it also tends to be expensive, and usually insurance will require a person to fail our other medication options first that also are used. Okay, so istradefylline or Nourions, this is a pretty recently FDA-approved medication in 2019. So it acts on a completely different receptor. All this time we're talking about dopamine receptors and dopamine. This acts on adenosine. And because it acts on a different receptor, it's thought to cause less dyskinesias, although the studies did see that patients who took this still had a risk of having dyskinesia. So it didn't totally eliminate that. And again, similar side effect profile, but it did reduce off time in about a third to a little bit more than a third of patients. And patients in those studies said that their overall motor symptoms improved by almost 50%. So I have not prescribed this medication yet, and primarily because it's also very expensive and hard to get insurance approval. But it's something new and interesting and something to watch out for, as we'll see how things develop with this medication now that it's in the market. So sometimes in Parkinson's disease, particularly in advanced stages, people can develop psychosis. Again, doesn't have to happen, but can happen. And this has to do with, all the different chemicals that play in the brain, including dopamine and serotonin. And Nuplazid, or pimavanserin, is a special type of medication that has been specifically approved by the FDA for psychosis in Parkinson's disease. So not any type of psychosis, but particularly Parkinson's disease psychosis. It does take 4 weeks at least to start seeing an effect, though. So that's the hardest part. If you or your loved one with Parkinson's disease is having hallucinations that are bothersome or scary, you have to wait and give this medication a chance to have an effect. And that waiting period, I think, sometimes can be hard, those like 4 weeks or 6 weeks before it kicks in. But I have seen this medication work really well. Okay, so I briefly want to talk about surgical treatments for Parkinson's disease. And I'm sure a lot of people will have questions about this. So deep brain stimulation is an electrode that's planted deep into the brain. Remember, those structures I showed you in the very beginning of this talk are very deep in the brain, that are those structures that are affected in Parkinson's disease. And no one really knows 100% actually how this works. It releases an electrical impulse into that area of the brain. And somehow that changes the way those circuits are functioning and improves symptoms. So it's not dopamine, it's not delivering a chemical or a medication. If you think of your brain as a bunch of wires with like an electric circuit, and that in Parkinson's disease, that circuit is somehow disrupted or not functioning well, the deep brain stimulation releases electrical impulses that disrupts that problematic circuit. And it is brain surgery, but the thing about this treatment is that it's not like you do one surgery and that's it. So you do a surgery to put in the electrode deep into the brain, and then there's this connection here. This is all under the skin, and it goes to the IPG, or the internal impulse generator. And this is basically like the battery that allows all the impulses to be sent. So this is all under the skin. This is right under the collarbone. And then we have a little computer that programs how much stimulation that is being released. So how much stimulation, the area of stimulation, all of this can be modified. And people can have this done on both sides of the brain. Sometimes we do one side and then the other. Sometimes you do both in one surgery. And really, so who should get deep brain stimulation is always the question. Generally, somebody who's having those motor fluctuations would benefit from deep brain stimulation. So when you start having those periods of ups and downs, in the past, people used to reserve this as an option for nothing else is working. But as time has gone on and we've gained more experience with this, we found that we shouldn't wait too long when we know it works well. And it does work really well. Like, people have told me they've gotten their lives back with deep brain stimulation. But how well it works really depends on appropriate patient selection. So if anybody was interested in getting this done, we would do special testing first to make sure you're a good candidate for this treatment. That involves coming to the office off of your medications, and we do an exam off medications, and we have all these scales to grade your motor function. And then you take the medication, we wait for it to kick in, and we repeat the scale. And then we look at how well the scale improves. So people who do well with deep brain stimulation are actually people who usually respond well to dopamine, with the exception of tremor. So tremor does not necessarily have to be very dopamine responsive to get deep brain stimulation, but all the other symptoms, we want to see a response to dopamine to say, yes, this person's going to benefit from deep brain stimulation. And then the person who's interested has to undergo neurocognitive testing. So it's like a 4 or 5 hour test. And the reason why this is important is because anyone undergoing brain surgery and being put under anesthesia are at higher risk of having cognitive side effects. And so we want to see, what is your cognitive profile like before you undergo surgery. So if you have a strong cognitive profile, that puts you at lower risk. If you have a lot of memory issues or problems with thinking, and you don't do as well as on the testing, then that means that you are at higher risk of having a worse outcome with undergoing surgery itself. And it doesn't necessarily totally preclude you, though, from getting the surgery. So really what happens is we take all this information, and as a team, so we sit with our psychiatrists, the psychologists, the neurosurgeons, everyone sits down together and discuss whether we think this person's going to really benefit from deep brain stimulation, and do the benefits outweigh the potential risks. Part of that decision making is also understanding what does deep brain stimulation help with. So it does not help with every symptom of Parkinson's disease. Particularly, it's great for tremor. It's great for dyskinesias. So there's parts of the brain that if we put a stimulator there, there's less dyskinesias. Or sometimes people can have less dyskinesias because having a deep brain stimulator can allow us to reduce the medications that you're on. And when by reducing the medication, you can reduce dyskinesias. It helps to reduce that on-off fluctuation because this electrode is always firing in the background all day long. And of course, then decreases off time. It's also good for the stiffness and slowness of movement. What it's not that great for is gait and balance. And if somebody wants deep brain stimulation because the volume of their speech is lower or they're having problems swallowing, it's not great for that. And we kind of already talked about that somebody who has problems with memory are already people who are not great candidates to undergo a brain surgery. So these are potential side effects. I know, of course, it is brain surgery, so we have to talk about, we're drilling a hole into the skull and accessing the brain. There's going to be a risk of infection, which is usually around 5%. We do very, very careful brain mapping. So what that means is before a person gets into the OR, we take pictures of the brain. We look very closely at the structures. We have these software computer systems that are specifically built to map out exactly where in the brain we're going for the surgery and how to avoid major blood vessels or other structures that, if we hit those things, those can cause problems. So there is a risk of stroke or hemorrhage if we go through a vessel or a structure that we shouldn't go through. And we are going deep into the brain, into these tiny structures. So that's why there's that risk is there. Across the nation is less than 5%, but actually at Hopkins, our rate is less than 1%. So that's a pretty good rate. And then the older someone is, the more risk of complications. Generally, that's true because older people tend to have other medical conditions along with Parkinson's disease as opposed to somebody's younger. So that's why, it's not something we should sit on if it's going to be beneficial for someone. And we know that this person's already having motor fluctuations. And we know in the future, they're going to even be a candidate. Doing this procedure on a younger brain is better than doing it on an older brain. I'll just put it that way. And we already discussed how it can allow for some reduction of medications, although most people will still require some level of medication, but maybe instead of taking a medication 5 times a day, 2 tablets 5 times a day, maybe they can take 1 3 times a day. So that's just an example. I mean, it's going to be different for every single person, but it does allow reduction of medications, which is nice. All right, so we're almost to the end of the talk here. I hope you're all still with me. I know this is a lot of information. But I did want to talk a little bit about clinical trials. There's always things being studied, and the goal is to, again, maximize quality of life and also to try to find ways to slow down the disease progression, or even maybe one day we can prevent it. I mean, that would be amazing. So, this was something, so disease modifying. So what that means is, like I said, a lot of the medications that we use now are all used to treat symptoms. They do not change the course of the disease. And, we want to be able to offer one day something that can change the course of the disease. So there is a trial going on. It's looking at this medication called exenatide, which is actually used in diabetes. And there's thought to be a relationship between insulin resistance and neurodegeneration. So that's how this idea even came up. And it was shown that patients who got once a week subcutaneous injections for 48 weeks. Individuals who got that compared to patients who got a placebo had so a 3.5 point advantage. So this is the scale that we use to measure someone's motor symptoms, the degree of motor symptoms that they have. Generally in Parkinson's disease, this scale increased by 2 points a year. So slow, pretty slow across the board. But apparently in this study, patients who took exenatide had a little bit of a lower score, which is a good, the lower the score, the better. Slightly lower score than people who took placebo. However, it was a very small study, and so more studies are needed currently in the phase 3 of the trial. And then this is also something in the pipeline, neuroderm. So we talked about Duopa, that pump that delivers dopamine directly into the jejunum. So that's a invasive procedure, right? A gastroenterologist has to place a tube that goes into the small intestines, and so this actually goes right under the skin, so it doesn't have to go into the stomach at all, which is nice. But otherwise, it's a very similar idea. It is still a pump, and the medication is still in liquid form and attached to a subcutaneous needle that infuses the dopamine. So this is not out yet, but this is something that's being looked at now and is currently in the works. So maybe sometime in the near future, this will be an option. And if you're interested in clinical trials, these are some ways to find clinical trials. So clinicaltrials.gov. That one has pretty much every trial that's out there, not just Parkinson's disease. Fox Trial Finder is much more specific for Parkinson's disease and sponsored by the Michael J. Fox Foundation. And then we have a research database as well. So if you're interested in trials, there's going to be inclusion and exclusion criteria for every trial. So the next thing would be to see, do you fit the trial requirements to enroll? Some trials may look at observational data, just learning about the disease. And then of course there's ones that actually have interventions. So I think that's all I have. All right, so that was a long lecture. But I hope that you got something out of that, and I'm happy to take questions.